Welcome to our last in our series of What's the Latest. I'm Mark Duncan, one of the regular hosts here, and I'm joined with my fellow co-host, Maureen Oskadel, and we'll be going through assessment and treatment of alcohol use disorders for our final installment. A couple of housekeeping things. If you could please sign in into the chat with your name, organization, and anyone else who's in the room. This helps us get through our sign-in process and just lets everybody know who's here. So let's go to the next slide. Also, this call is being recorded, and if you're not speaking, please keep yourself on mute. You can see the controls there, as is most of the Zoom calls. Next slide. So for our agenda today, we'll start off with our land acknowledgement, then I'll turn things over to our special speaker for today, Dr. Essali, and then we'll open it up for some questions and discussion. If there are questions that come up along during the presentation, if you want to go ahead and type those into the chat, that's a great way to kind of put those in the queue, and we'll get to as many of those as you can. Of course, after the presentation is over, we'll open it up for just some spontaneous unmuted questions as well that you can list. But if you want, go ahead and putting those into the chat is a great way to kind of hold your spot there. And again, we'll get to as many of those as possible. All right, so I'd like to start off and just state that I'd like to begin by acknowledging that as we gather today, we are on the ancestral homelands of the indigenous peoples who lived on these lands since time immemorial. Please join me in expressing our deepest respect and gratitude for our indigenous neighbors. Next slide. All right, so with that, I'd like to introduce our speaker for today. So we're fortunate enough to have Dr. Norah Essali. Dr. Essali is one of our addiction psychiatrists here at the University of Washington and works mostly in the Harborview Hospital and at the addiction clinic at Harborview County. And he's an assistant professor here. And Norah, I'll turn things over to you to fill out your bio and kind of start your presentation. So again, really appreciate you talking to us today on the assessment and treatment of alcohol use disorders.
Thank you, Mark. Yeah, you got most of my bio. I'm all at Harborview Medical Center. I work at the Harborview Mental Health and Addiction Services and on the Addiction Consult Service. And I'll be talking to you today about alcohol use disorder, its assessment, and mostly pharmacotherapy treatment. And then we can discuss a couple of points as pertains to when comorbid with opioid use disorder. So we'll first kind of review how we can assess for alcohol use disorder and the pharmacotherapy options, and then some considerations with OUD. To start us off, just kind of a reminder that we still see a lot of stigmatizing language used when talking about substance use disorders and people who use substances. So just a reminder to always use person-first language for talking about addiction. So instead of calling someone an addict or a user or a junkie or any of those terms, saying they're a person who has, a substance use disorder of any kind, avoiding stigmatizing language like clean or dirty for urine drug screens, for example, or saying someone's clean when they're in recovery or are in remission from their substance use disorder. So just keeping that in mind, because we're doing better, but it's still out there. And then the other thing I'll mention before we get started is just to remember that substance use exists on a spectrum. There are, of course, people who don't use at all. There are people who use substances as part of, maybe some social low risk use, just like, maybe having a drink on the weekend. There is ritual and kind of ceremonial and religious use of certain substances, especially in like indigenous populations and others. And then, of course, as we move towards kind of more frequent, more often or heavier use of substances, we get into the higher risk use where you could have, accidents and negative consequences. And then when it becomes regular, compulsive, despite negative consequences is when we move into the addiction realm of that spectrum. So just also wanted to keep that in mind.
Norah, before we get into the meat here of your talk, you able to talk a little bit louder? Some of our participants are having a hard time hearing.
Okay, let me know. Is this better?
Yeah, thanks.
Okay, great. Okay, so why is this important? So alcohol use disorder is very prevalent in the United States. It affects almost 10% of our population. Um, and past alcohol use is also common even when we don't have a use disorder. So almost 62% of the population drinks alcohol at some point in the past year. There are over 4 million emergency room visits related to alcohol use and over 170,000 deaths related to alcohol use. So it's a very common, it's the most commonly used substance in the United States and the most common cause of death as well in terms of substances. And so it's really important that we talk about it. In Washington State specifically, it is one of the top two reasons people seek treatment. So as you can see, kind of alcohol and then opioids. This is a bit older data, it's the most recent that I could find. And then even in the past year, if you look at alcohol-related crashes and deaths, you have over 4,000 alcohol-related car accidents that happened in Washington State just in 2024. So not even, the year is not even done. Um, and so when we're trying to assess our patients and kind of understand where they fall on that use spectrum and where do we need to intervene and help out with, we have to help them understand what is low risk drinking, help them define that, and then they can share with you where they think they fall on that spectrum. And so the most up-to-date dietary guidelines for Americans recommend that men don't drink more than 2 drinks per day and no more than 14 per week. And for women, no more than 1 drink per day and no more than 7 per week. Anything above that, you start to kind of move away from moderate or low risk drinking. And they define that based on studies that show that any amount of drinking above that increases all-cause mortality, increases risk of, cardiovascular disease and stroke. And so that's what these numbers are based on. And so if people are drinking, men are drinking 5 or more drinks in 2 hours or 4 or more, which you might hear commonly, on the weekends or people in colleges or partying and that sort of thing, that accounts for binge drinking, and which can, fall under the high risk and risky drinking that we worry about. Another thing that's important to remember before we dive into assessments is people's definitions of drinks is very different. So they might tell you, oh, I just have a beer a day. But if you kind of look here, one beer or what would count as 1 drink is a 12-ounce beer. And so if somebody's drinking the 24-ounce or the high alcohol content, also beers as well, that's counting for more than 1 drink. So it's also always helpful to share this with your patients and kind of bring that to their awareness of what would count as 1 drink so that they're counting their drinks accurately as well. And so when you're moving towards assessing if they have alcohol use disorder, generally you're going to be asking based on the DSM-5 criteria and asking about their use in the past year. And all of these questions, these 11 criteria, are basically determining, is this person drinking more than they want to, more frequently, more often? Is it occupying so much of their time that they're letting go of their responsibilities, that they're having emotional, psychological, or physical harm from it, that their relationships or their jobs or their functioning is being impacted, that they're having withdrawal symptoms, that they're having cravings, and they're continuing to use despite all of that. And that really kind of comes out to a definition of alcohol use disorder as a chronic relapsing brain disorder characterized by an impaired ability to stop or control alcohol use despite negative consequences. And so if they meet 1 or 2 of those criteria, then they're in a mild use disorder. Sorry, 2 or 3. Then if they're 4 or 5, then moderate, and anything more than 6 is a severe alcohol use disorder. And that matters in terms of the intensity of treatments and how much support they may need. So defining that severity can help you determine that as well. And so to sum all of that up and just kind of, I like to think about it always as the 3 C's of alcohol use disorder. So it's the loss of control, the continued use despite negative consequences, and then cravings for alcohol use. And so, despite in the United States having almost 30 million people who have alcohol use disorder, and this is according to the National Survey of Drug Use and Health in the United States, and this one just from 2023, only 10% of those people, or less than 10%, receive any treatment for alcohol use disorder. And that, by any treatment, that includes, going to a residential treatment or going inpatient or receiving any sort of therapy or anything for alcohol use disorder. For medications for alcohol use disorder, it's even less. So in 2023, only 2% of those 30 million people received medications to treat alcohol use disorder. And that's really concerning because we're in 2024 and we've had meds approved since 1949 for alcohol use disorder. So the word is not out yet, and we still can do a much better job, especially when we know that alcohol use disorder has a really high return to use rate, especially when you're on that moderate to severe spectrum of the disorder, with 70 to 80% going back to using within a year after going through detox treatment. And because we know that medications for alcohol use disorder are really good at reducing return to heavy use or use at all, they improve people's retention and treatment, and they reduce healthcare costs, and they improve mortality. So, this chart here shows you that in the red are patients who are diagnosed with alcohol-related cirrhosis and were started on medications for alcohol use disorder, and within the first year after being diagnosed with cirrhosis. And the ones that got prescribed those medications had better survival overall as compared to those who didn't. So lots of benefits from these medicines. The same survey that has given us all these numbers of prevalence of treatment and how many people are getting treatment also asked people why they're not getting treatment. And you'll notice the theme of these are kind of the responses here. And the theme that comes out is patients think it's too cumbersome. You have to kind of go through detox or residential or quit your job or tell your family or, face the judgment that has to come with that. Or something bad will happen to their kids, or they got taken away from them, or it's too expensive, can't pay for it. So again, all of it really highlights how having something simple like going to your primary care doctor or whichever doctor you're interfacing with, and they help you with getting started on medication, is like a really easy step into treatment. And then if they need further treatment on top of that, like therapy, like counseling, like support, that could be explored later. But this is something that's going to be pretty low barrier and accessible to folks who worry about these things. So how do these medications work? It helps to understand how addiction develops, and then that kind of helps us understand why medications are important in a lot of the moderate to severe substance use disorders, including alcohol use disorder. So in the kind of development of addiction, we have multiple neurotransmitter systems that are involved. So in that first stage is the binge intoxication stage. That's kind of everybody who drinks. You're going to drink, you're going to get a buzz, you're going to get a good feeling from drinking. And that's because you have some dopamine release, some endorphins released, and some GABA release that can kind of be relaxing and disinhibiting while at the same time giving you a buzz. And so once that's happened a few times, your brain starts to learn, oh, this is a good thing for me. This is a helpful, positive thing. So it starts to develop that incentive salience, which goes back to the frontal part of our brain and teaches it like this is something important for your survival. So if you have a predisposition to developing an addiction, and usually that comes from biologic predisposition, family history, stressors in the environment, trauma, all sorts of factors, you then kind of persist in drinking. So as you persist in going back to that, seeking that binging and buzz and good feeling, you go back to drink often. And then eventually you start to develop a negative state from that because it's a depressant and because it starts to impact your health. But also when you're not having it around, you're now having withdrawal symptoms from not having it. So now you're not really feeling the reward as much and you're more in a stress mode, but you've already learned that it's kind of a good thing for you. So you go back and that kind of reinforces to your brain that not having it feels bad as well. And so now when you try to stay away from it, your brains, your frontal lobes are now have gotten two messages that this is good for you, this is needed. So when you don't have it or you try to take a break, you're now in this preoccupation anticipation stage. You're thinking about it, you're craving it, you're planning to go get it. And then the next thing you know, when you're in a vulnerable position, or, you know, we hear things like people, places, or things that trigger cravings, you find yourself drinking again. So there's this exaggerated incentive salience that people learn from their use. And so what medications do is they come in and they restore the balance between your frontal lobes and your reward system, so that your reward system isn't driving the show as much, and that you're able to kind of think, complete the cycle of thinking, and be less impulsive about going back to using despite the negative consequences. So we have several FDA-approved medications, and a few off-label ones that we don't have time to go into today, but we'll just focus on the FDA-approved ones. So disulfiram, naltrexone, acamprosate, and then long-acting naltrexone, which we'll talk about each of them in detail. First up is naltrexone. This is an opioid antagonist, and as we saw from the previous slide, endorphins are involved when we're using alcohol, and those are your endogenous opioids. And so if you introduce an opioid antagonist, you're going to block that internal response to the endogenous opioids. And so that's tied into dopamine release as well. And so by that, you're moderating that rewarding response to alcohol that you get. And so you're blocking the pleasurable effect, and you're helping the brain dissociate that idea that this is a good thing for me, this is a rewarding thing for me. In the initial trials that led to its approval, you can see naltrexone here on both those charts is in the dark bolded circles and lines. And in the top left chart is showing that folks who are on it were able to stay longer without any return to use. And this is over a 12-week trial in that first stop. So they had less cravings, less drinking days, and their liver enzymes even looked better. And then in the bottom chart, and those who did return to use, so even though they weren't totally, sorry, the bottom chart is the cravings, but in the same trial, the folks who did return to use, the naltrexone decreased their use from sampling or prevented it from going from sampling to heavy drinking. So it helped people stay off of drinking. And then in those who went back to drinking, it didn't return to as heavy as it was before. And then afterwards, in multiple, meta-analyses summarizing many trials, including the most recent one was 54 randomized controlled trial, it's affirmed this finding over and over again. It's really helpful in reducing heavy drinking, and it's really helpful in improving abstinence. They did find that it may be better or more effective at reducing heavy drinking than leading to complete abstinence. So that's just something to keep in mind. But in either case, it's helpful for both outcomes. And it's helpful for reducing or helping the liver and reducing kind of liver enzymes as well. Another helpful use for it for you to know about, so let's say you're assessing people and they're falling on that spectrum of use, not really at an alcohol use disorder, but maybe they're at a high risk or unhealthy use, they're drinking above the moderate drinking levels, they're not really having a good time with being able to stop or limit that use. So you can use naltrexone in a targeted way. So this study specifically looked at people who just have unhealthy drinking, not necessarily a use disorder. And they gave them a limited amount of naltrexone pills, and they told them to take it only when they anticipate they're going to be in a high-risk situation, like going to a party with friends or anything like that. And so the targeted naltrexone and the daily naltrexone is in the dashed lines at the bottom of the graph. And you can see from week 1 to week 5, they both did better than placebo at reducing the probability of heavy drinking. And then you kind of see the targeted naltrexone starts to perform worse at week 5 and goes back to join the placebo chart. And that's because people ran out of pills. They gave them a certain number of pills that they can use. So as long as they had it, they did well. And then when they didn't, they went back to heavy drinking. So that's really important to keep in mind as well. It's helpful even for those without necessarily a use disorder, but just unhealthy drinking. And you don't need to take it every day, just targeted. The other form of naltrexone is the extended release one. This was approved based on a 6-month study in about 600 people, and they found the 380 milligram dose per month reduced the event of heavy drinking by 25%. And they showed that the patients who were abstinent by choice for about a week before treatment had the most robust effect. So you might see in the package insert from the naltrexone extended release is that you have to only use it in people who are abstinent, so you can only start it in people who are not drinking. But later studies have shown that that's really not necessary. In a meta-analysis of 7 trials, they found it still reduce heavy drinking. And it's even in people that didn't really require pre-treatment abstinence. So you definitely don't need to require people stop drinking. And they also saw that it does seem to recruit more effect the longer people stay on it. So if your patient took the injection one time, didn't do as great, encourage them to at least stay on it for 3 months, because it seems to have kind of a stacking or a building up effect that shows better outcomes in more than 3 months on treatment. So for naltrexone as a whole, whether long-acting or injectable, the only times you cannot use it is if there's an acute hepatic impairment. So if you have chronic hepatic issues, cirrhosis, that sort of thing, that's totally fine. You can still use naltrexone. You want to avoid it in acute hepatitis or in decompensated cirrhosis. And of course, because it's an opioid antagonist, you cannot use it in someone who's on an opioid already, which is why we're going to talk about OUD a little bit later. And as long as there's the liver, if there is some hepatic impairment, as long as it's not more than 5 times the upper limit of normal range of liver function test, you can still use it. You do need to get a baseline LFT. You don't have to, withhold it. If someone looks clinically stable, you can get it at some point once started. But in terms of ongoing monitoring, there isn't really really good data to guide us on that, because everything we've actually seen in studies is that naltrexone is really helpful for the liver. So you don't necessarily need to monitor as frequently, as long as you know that somebody is kind of clinically stable, doesn't have decompensated cirrhosis or acute hepatitis. Common side effects are going to be stomach upset, diarrhea, nausea. Typically that goes away within a week or so. Dizziness, and then if you have obviously the injection, there's going to be injection site pain. A long-acting naltrexone should be on in your toolbox, especially if someone struggles with taking pills. You really want to think about that very quickly and early on. It's really helpful for folks. And then patients are going to ask you, can I drink on naltrexone? And the answer is yes. It's not like disulfiram, which we'll talk about next. It's not going to make you sick, but you might feel intoxicated sooner, which may be part of why it helps people stop drinking and the same amounts that they were drinking before. Next up is acamprosate, and this one works likely, we don't know, but likely works on modulating the balance between GABA and glutamate transmission. And so glutamate is the neuroexcitatory neurotransmitter that really is involved in the restlessness, anxiety, insomnia, and cravings that are seen in kind of withdrawal and post-acute withdrawal states. And so acamprosate is thought to kind of bring back that balance and enhance GABA, which is more calming and inhibitory neurotransmitter. Lots of studies on it, meta-analysis of 35 of those showed that it's really helpful for abstinence. It's really helpful for heavy drinking. It's fairly tolerable, not really significant adverse events. People don't tend to drop out when they're on it. So again, a good, helpful option for you. Similarly to the long-acting naltrexone, it does seem to do better as people stay on treatment with it. So this chart showing kind of the average of heavy drinking decreases the longer people are on acamprosate. So just also keeping that in mind if people want to give up after taking it for a week or 2. Disulfiram is the last FDA-approved medicine we'll talk about today. this is something that if you talk to patients about medications for alcohol use disorder, this is probably what they're going to think of first and say, no, 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 I don't want any medicine, because they know, probably have heard about it. This is a medicine that's called antabuse or disulfiram, and it's going to make you sick when you drink on it, and that's because it blocks an enzyme, aldehyde dehydrogenase, that is involved in the metabolism of alcohol, and that leads to accumulation of acetaldehyde, which causes something called a disulfiram reaction, which is what patients describe as, feelings or getting sick. And that can be also on a spectrum of severity. So some folks only experience sweating, flushing, skin flushing, and warmth. And then, later on, you might have the nausea, vomiting, confusion. Rarely or occasionally, you might have bradycardia and kind of significant cardiovascular issues. And then much, much more rare, you might have myocardial infarction or seizures or psychosis or cardiovascular collapse. So this isn't something that we want to mess around with per se. It can be really uncomfortable. So if patients are, not really ready for abstinence, this isn't something you want to enforce. If they have, any cardiac issues, we tend to avoid that, especially in severe cardiac issues. And then the other thing to remember is you might hear patients say, well, I can drink on disulfiram and not get sick. And then others who might feel a bit of flushing, even if they use like a hand sanitizer with a little bit of alcohol in it. And that's because of, that goes back to how much of this enzyme, the acetaldehyde dehydrogenase, that they have and how much reserve they have. So if they have a lot more, then they can take some disulfiram and still have some function reserve, so they're able to drink on top of it. And if they have a lower reserve, then they're going to be very sensitive. And again, in studies, it's been shown to be helpful. It's been approved since, based on this VA 1986 study. And it showed that it was helpful in reducing return to use, but also in reducing the amount of drinking once people went back. But the interesting thing is only 20% of that study population really took it. And so those good outcomes were in those who took it. And then later in systematic reviews of it, they also saw that it's really helpful in patients who take it, obviously. And so really we kind of recommended, if there's a supervised kind of situation, it seems to be most helpful because you're ensuring adherence, and people are going to take it and likely not drink. So some case scenarios I've had a lot in clinics of if somebody and their spouse, for example, are trying to build trust again, they're trying to show that they're committed to treatment and trying to avoid drinking. And then the spouse is kind of supervising that administration in the morning. And that tends to be really helpful for both of them. And then we know the patient's taking it, so it will work for them for abstinence only goals. And so, you want to guide your patients on testing any products that may have some alcohol when they're taking disulfiram to make sure they're not too sensitive. So whether that's, like cooking alcohol, mouthwash, patch test, any topical products that may have it. They have to have stopped drinking for at least 48 hours before. And again, this is only for patients who really want to stop completely, not those that just want to moderate their use. And then in terms of combining these medications that we talked about, just to kind of help you understand why we might go for naltrexone first, is a lot of studies have shown it to be helpful more than combinations in and of itself. And so if you start with acamprosate, for example, this study shows that naltrexone alone is actually better than acamprosate. But then let's say your patient came in on acamprosate and had some partial effects, then adding naltrexone to that tends to be more helpful than just acamprosate. But as a first-line treatment, as the medication to start with, naltrexone tends to perform better, so you can feel good about starting that as a first-line treatment. It's also a once-a-day medicine, where acamprosate is 3 times a day, so that's also a lot easier for patients. And then there's a lot of thought of, well, people need to be in therapy for them to receive medications, and if they're not on therapy, nothing's going to work. And there's lots of stuff going on the slides here, but it's mostly to show you that naltrexone alone or cognitive behavioral intensive therapy alone did equally good. And so if your patient does not have access to therapy, you starting them on naltrexone is still a good thing and is still going to help them. The one off-label medicine I'll talk about a little bit is gabapentin here, because you will see it used quite often in people with alcohol use disorder, and it should be a tool in your toolbox as well. Again, that GABA transmission can be really helpful, especially in the early withdrawal stages, the insomnia related to alcohol withdrawal, the restlessness, the anxiety. And then we see trials that show that, you know, combining it with naltrexone does better than either medicine alone or than placebo. So it can be helpful to think about adding that on if needed. And so when you're trying to choose for your medicine, for your patients which medicine to choose, you want to ask them, what's their goal? Is it abstinence? Is it moderation? Both are good. Health outcomes improve significantly with either of them, even just reducing and not completely abstaining. And patients have higher success when they tend to choose their goals. Again, avoid naltrexone in acute hepatitis, liver failure, or concurrent opioid use. Acamprosate is metabolized through the kidneys, so you don't want to use it in severe renal impairment. If adherence is a concern, injectable naltrexone is going to be your friend. More disulfiram is a little bit better if supervised, and the last one is going to be acamprosate, because it's a 3 times a day medicine, so taking it with someone who has adherence issues might be difficult. And then if you have a partial response to one medicine, think about combining it with another to get more response. Okay, little break. This is my dog, Winston. We made it through the first part. And now let me do time check. Okay, we still have time. Good. And now we'll talk about opioid use disorder a little bit. So a couple of things. So most of you who work with people with substance use know that generally they're not going to be using just one substance, and specifically in people who have opioid use disorder, about 20% of them will also have alcohol use disorder. And this is kind of based on national data, but then when we zoom into King County, in fentanyl involved deaths, alcohol was involved in about 17% of them. So, you know, about 20% involvement all in. And so it's something that if you're treating people with opioid use disorder, you also want to be asking them, of course, about other substances that they're using, and most commonly, or one of the common substances is going to be alcohol. And another interesting thing that's kind of come up with the fentanyl era, this study looked at, you know, how people's development of opioid use disorder changed over time. And so this is in patients that presented for treatment for alcohol use problems. And they split them into cohorts, the first cohort being people who started using painkillers in the 2007, 2009, and then 2010 to 2012. And then the third cohort was those who started using fentanyl from 2013, 2016. And cohort 3 is that dashed line on the top in the graph, and that's fentanyl. And it's showing you that the folks who use fentanyl tend to, if they start using it here and there, they tend to develop an opioid use disorder much quicker than people who used, you know, previously painkillers or pills or pain pills before, were common before fentanyl. And so these are in patients who are presenting for alcohol use disorder treatment, and we're seeing that if they are misusing fentanyl here and there, they're at higher risk than prior cohorts at developing opioid use disorder within that first year after admission. So keep it on your radar and ask people about their use. And then vice versa, you know, if you're trying to treat alcohol use disorder and people are misusing opioids here and there, the bottom kind of bold graph just shows you that folks who misuse opioids while they're receiving treatment for alcohol use disorder tend to more quickly go back to heavy drinking than folks who don't. So addressing both issues will help with treatment outcomes as well. And a lot of studies have shown that people who have both opioid use disorder and alcohol use disorder are more likely to have health problems, mental health problems, treatment retention issues. And yet the study showed that they're less likely than people who have one or the other to receive any pharmacological treatment. So more than 60% of people who have both disorders received no treatment at all, which is terrible. And then if they were to receive treatment, those who have alcohol use disorder and opioid use disorder were much more likely to receive naltrexone or oral or extended release, which makes sense from a conceptual, thought of it's approved for both. It helps blocks the opioid receptor, which helps with both. So people, are thinking we should just start that and help them for both disorders. And they're much less likely to receive buprenorphine or methadone for their opioid use disorder if they had alcohol use disorder. The discrepancy that I'll show here is that idea that naltrexone will be most helpful may not be totally accurate. And I'll caveat this with, we really don't have studies, randomized trials, really good studies telling us how best to treat people with opioid use disorder and alcohol use disorder. But I just want to put this out there to not so that you don't feel like if you have to force your patient to be on naltrexone specifically if their preference is for methadone or buprenorphine when they have alcohol use disorder. And so to not feel compelled to treat their OUD with methadone buprenorphine, because this study actually showed us that retention rates for patients who have both OUD and AUD were actually much better in the methadone and the buprenorphine group than the naltrexone group. So at the end of the day, just kind of highlights this is patient choice, patient preference, their prior treatment experience, and the data supports your decision and their decision, and not necessarily having to go the naltrexone route if that's not what they want to do, because unfortunately it's not being shown so far that it's a much greater protective effect on treatment retention for people with both. And then the other concern, with people who drink alcohol and also have OUD, and then you're treating them with an opioid like methadone or like buprenorphine, is that, you're leading to overdose risks or, risky health outcomes. And so another kind of highlight here is that people who had OUD and were on these medications and had recent AUD claims as well, actually had reduction of odds in admission for alcohol-related acute events, with the most reduction being for methadone, and then buprenorphine, and then extended release naltrexone, and then oral naltrexone. Not sure why, why is methadone the most helpful when it's the full agonist opioid that we worry about most potentially with alcohol use disorder? Maybe it's the structure of methadone clinic and having to attend regularly. Maybe that helps moderate how much you're drinking, and your urine's being tested and you have access to some counseling support there. That might be it. But again, just to highlight, don't worry about it. Treat both disorders and treat with what your patient wants. And just kind of me looking at this, the literature for this talk, really it just highlighted, we need a lot more research in knowing what to do when people have both of these disorders. A lot of the trials tend to look at them as separate entities, even though we know that there's a lot of comorbid use. But also a lot of what's already out there just highlights how common the use is, how we all need to be doing screening ongoing. So just because at intake, maybe they didn't have both substance use disorder, keep making sure you're checking in about other substances and how risky and where they're falling on the spectrum of use, and offering treatment. And obviously we need a lot more research in this area. So in summary, discuss treatment options for both AUD and OUD. For OUD, decision of whether to use buprenorphine, naltrexone, or methadone is guided by the severity of the opioid use disorder, the patient's past treatment, experience, and preference. If their opioid use disorder is mild and they really don't want to be on an opioid agonist and they can tolerate withdrawal process and they have AUD, then yeah, naltrexone and long-acting naltrexone preferably would be a good choice. For those with moderate to severe opioid use disorder, you can still offer methadone and buprenorphine if that's their preference and they don't want to go through that withdrawal process. And then if you end up in that group of people being on buprenorphine and methadone and still have active alcohol use disorder, you can't use naltrexone. So you've got acamprosate, disulfiram, gabapentin, or a combination of those three to help them to start with. And then beyond pharmacological treatment, obviously that's a good first step in the door, but you need to be checking in with them regularly, bringing them back for appointments, asking them what they're doing in terms of managing triggers, risky situations. Are they attending groups? Do they want more support like therapy? Are they kind of pursuing recovery-oriented activities? And I'll show you a couple of things you can point them to. But for you, there's this really cool resource page, pcss-maud.org, and it has lots of online videos and trainings, but also digital resources that you can print out and share with your patients and for yourself. And so if you click on digital resources, this is the website it'll take you to, and this is an example, for example, like the PDF for a summary of medications, everything I just talked about. You can print that in like one page and share it with folks. And then the National Institute on Alcohol Abuse and Alcoholism also has this cool website that you can know which mutual supports option groups there are, also medication guides, also therapy manuals if that's something you want to implement, and other resources to share with your patient. For Seattle specifically, if your patient, got started on medicine, is seeing you, they want more support mental health wise, they want groups, they want counseling. If you call the Washington Recovery Helpline with them or help them call, can help them connect to a mental health agency that can work with them. And then Recovery Cafe and Peer Seattle are a great local resource for groups and support for people who want to start building a recovery network as well. And there's all of the studies in here. And Winston, thanks you for listening.
All right, thanks, Nora. I really appreciate that. Great overview of the assessment and pharmacotherapy for alcohol use disorders. So let's take the last 17 minutes here and open up for some questions and comments. There was one already put in by Mullane, and sorry if I mispronounced that. And they're asking, what is the current best practice for alcohol withdrawal? Where would we find protocols for maybe inpatient settings? What are your thoughts on that? And yeah, we'll go from there.
Yeah, that's a good question. And yeah, I wish I can kind of go over all of the aspects of treatment, but obviously in 1 hour, that's tough. But part of the assessment for alcohol withdrawal is really seeing if somebody has a history of complicated withdrawal or not. And so a complicated withdrawal meaning they have history of delirium tremens, seizures, really severe withdrawal that leading to those issues. And so in that case, we would want to pursue inpatient treatment. Off the top of my head, I would say UpToDate is your best source for looking at up-to-date information for treatment algorithms. SAMHSA, ASAM, all of those have resources as well for providers and withdrawal management. But ultimately, the idea is if somebody has that level of severe withdrawal leading to complications in the past, like seizures or delirium tremens, you do want to pursue having a scheduled dosing of either phenobarbital or benzodiazepines, and then using as needed symptom triggered management on top of that to minimize risk and increase patient comfort while they're being treated.
Thanks, Nora. And you had mentioned the ASAM one. I did put the link to the ASAM practice guideline on alcohol withdrawal management in the chat, so you can look for that. And for those of you who have not heard about Scala Northwest or Scala, SCALANW, that will have some protocols to be released around alcohol withdrawal management, in addition to some resources around treating opioid use disorder. So take a look at that website. There's a lot of work being done around that. That's be very helpful for providers working with substance use disorders, especially in ED and inpatient settings, but more than that. And thank you, Mandy. Mandy Sladkey is kind of coordinating this whole project, and she put the website in the chat to look at. Again, the alcohol withdrawal is not there yet. It is in the process and will be there shortly. And I don't know if Mandy, you have a timeline on that, but something to look forward to.
Yeah, we have a draft, and Dr. Essali, I'll be reaching out for your input for alcohol withdrawal and alcohol use disorder treatment initiation in the ED. And it'll take maybe like a month or so to iterate on that, and then another month or so for publication. So maybe in a few months.
Okay, great, thanks. All right, so yeah, additional questions. I don't know if that answered your question, Elaine, about the alcohol withdrawal. And thanks, Verna, for the feedback on the resources, and Brittany. Other questions or comments for Dr. Essali? Well, while we're waiting for someone to kind of chime in, I did want you to speak a little bit to, some of the potential challenges of starting someone on buprenorphine who's actively drinking, and maybe they're even at a alcohol use disorder level, maybe they're not. What do you tell people about, getting started on buprenorphine, and how should they manage their alcohol use during that time? Do you do that even in an outpatient setting, or is it too complicated and you're like, well, let's find an inpatient setting to do that?
Yeah, that's a good question. I think it depends on the severity of either substance use disorder. And so if they're, still ongoing drinking, but they're trying to at least quit the opioid use part of things, I wouldn't necessarily recommend that they also try to stop alcohol use at the same time, because you don't want to get into that complicated picture of withdrawal from both substances. And that withdrawal can look and share a lot of the symptoms as well, which can be difficult to navigate. So I would encourage you to try to tackle one substance at a time. Obviously that's can be more on the challenging side if the level of alcohol use is so much, and to where there's frequent sedation or altered mental status, and that kind of level of severity, then you might not want to approach that on the outpatient side, and kind of leave that to more an inpatient level of care. But if there's someone who like is binge drinking here and there, or has daily use, but not to that level of where they're altered, and you're worried about their alertness and their breathing and that sort of thing, then you can pursue starting buprenorphine as you would with anyone else.
Great, thanks, Norah. So Eddie, you have a good chat in here. Hoping you can unmute and walk us through your question.
Hello, can you hear me?
Yeah.
Yes, we can.
Yeah, cool. Thanks for that helpful presentation, Nora.
Sure.
And yeah, common situation. We have people on methadone at our OTP.
Mhm.
Not rarely they're drinking to varying extents, and there's a sort of a reflex response. Oh, we've got to decrease their methadone dose, or we've got to decrease their take-home status. So we have to keep a closer eye on them. Meanwhile, the patient doesn't see their drinking as a problem. They've probably been doing it for years before we noticed. And so our alarm bells, I'm suspecting, also sort of lead to an erosion of trust in us
Mhm.
to a certain extent.
Mhm.
And I tried to survey the literature about specifically people on methadone
Mhm.
and drinking, what's shown to be uh, beneficial. And I didn't come up with much. So I'm
Yeah.
curious if you could offer us any guidance besides reflex, intuitive, not well,
Yeah.
evidence-based approaches.
Yeah, absolutely. Yeah, it's a really challenging, issue. And Edward, I share your same kind of problem as I was looking to kind of prep this talk. There isn't that much data about people who have both, but at least the couple that I saw, and I can try to go back in my slides here a bit. The couple of studies that I did see, kind of based on claims data and looking at safety outcomes and retention outcomes, actually favor methadone. And so in this study here, I don't know if you can see my slides still, but the folks who are on methadone and had alcohol use disorder, so not just abusing here and there or, you know, heavy use here and there, but like had regular alcohol use disorder, did better retention wise when they were on methadone than when they were on buprenorphine, naltrexone, or oral naltrexone. And then there's the other one with ED related visits. Again, those with methadone did better. They had less presentations to the emergency room or acute events regarding falls, injuries, overdoses, poisoning, which is what we always worry about with methadone and alcohol. And so I think your instinct is correct in avoiding eroding that trust by changing methadone dosing or threatening their retention in the methadone clinic, because it does seem to be helpful, and rather kind of going the route of exploring with them why they're using alcohol, what it's doing for them, what they're trying to treat with it. And then, you know, maybe sharing some of those initial things we talked about of, are they aware of what moderate drinking is? Are they aware of, you know, what use levels could be more harmful? Have they thought about cutting back, not necessarily stopping? You don't really want to, they're not ready to go to abstinence completely. Even cutting back can be helpful. And then offering some of those medications that can help, like if they're on methadone, you can do a acamprosate or a disulfiram or gabapentin. I think there was a long time ago study or maybe case report or something about methadone clinics putting disulfiram and administering it at the same time with the methadone. And so that's part of that supervised requirement for disulfiram. And it's obviously was helpful, and people were not using opioids or alcohol. And so you may be well placed at an OTP to do that supervised portion as well. And so, yeah, I think the short answer is we don't have good data. Long answer, the amount of data we have so far is reassuring. If your patient's on methadone and drinking, it's probably okay. They're neuroadapted. They're not going to have acute issues. And then just exploring their alcohol use motivations and what they want to do with it with them.
Thank you.
Thanks, Eddie. Great question. And thanks, Nora. Okay, Verna has chatted in. Verna, I don't know if you're able to unmute and walk us through your question here.
It was just kind of I guess a general question. I noticed at the beginning of this presentation that you noted that there had been a decrease in deaths related to automobile accidents while under the influence of heroin, and that there was an increase in deaths related to driving under the influence while driving under the influences of alcohol. One of the things that I've noticed and that we've seen a lot of documentation and a lot of data on is that fentanyl is starting to replace heroin, but I didn't see that on there. So I was wondering if you had any information relating to.
Yes, actually, sorry, I think that was a bit of a confusing slide. So the graph showing alcohol and heroin is showing treatment admissions. I was just showing that, and this is old because that's the last report from King County, and that was from 2018. And so yeah, fentanyl I think is not incorporated in this as much, but I was just showing in this graph that the most commonly sought treatment was for alcohol and opioids, and that includes heroin. And then the other chart on there was just showing how many car accidents we've had in just 2024 related to alcohol. I think it would have been helpful if I put them in separate slides. Sorry, I know that must have been confusing.
Thank you so much for clarifying.
Yeah.
And then Heather had a great question about the impact of naltrexone. And I don't know, Heather, can you unmute and walk us through your question? Well, if not, I'll just kind of read it out. So Heather asked, how is general pleasure affected when taking drugs like naltrexone, which dissociates the reward with drinking, as you described? And how does it affect natural dopamine reward that comes from exercise, food, sex, etc.?
Very good.
We want people to do
yes.
And
Very
enjoy,
Yeah, absolutely. Anecdotally and theoretically, yes, when you're blocking some part of that reward system, you could have, reduction of that enjoyment, which, we've read about in some places or heard about anecdotally, but in treating patients for, my limited time of, few years, I have not had that to be an issue that patients complained about. They're still able to go about their lives and enjoy. And my thought about that is when you're having that reinforcing effect towards something like alcohol or whatever the drug of choice is for the patient, there's too much reinforcement, and the naltrexone is helpful at kind of reducing that over response basically, and not necessarily impacting everyday reward and pleasure and response, but it has been stated by patients. And so it's possible. I don't know how common it is. I don't know, Mark, if you know like data specifically on this, but it's not something that I've seen in my practice lead to patients not wanting to be on the medicine or feel like their quality of life is impacted.
Yeah, I would agree with that, Nora, and that's been my experience as well. Is I don't see the everyday pleasures impacted as much, or really at all. Interestingly, I did find a paper real quick that looked at this, and I put the link in the chat. And their conclusion was that the differential hedonic ratings or pleasure ratings in patients who persist with long-term Vivitrol therapy they find that it selectively inhibits the pleasure associated with drinking alcohol compared to a variety of other activities. So you're kind of highlighting, it's tempering the excessive pleasure and euphoria related to alcohol and the dopamine release of that versus, say, like eating, sex, exercise, and so forth. So it's very interesting how you see that selective response, which kind of corresponds with what we were describing clinically.
Mm-hmm. Thank you. That's awesome. You found that so quickly.
Yeah, I've gotten good at looking it up very quickly with PAC. Anyway, we have like 2 minutes left. Does anyone have another question or comment for Dr. Essali? I guess one comment I'll make is that I'm always surprised by how good OUD treatment, buprenorphine, methadone, whatever, is working for that person can generalize to other substances. So even though you may be in a situation where we may not feel like we have a lot of treatment options, maybe for a specific substance, or maybe someone's not super interested in addressing their alcohol use or meth use. Really good OUD treatment can generalize and help reduce some of those other substances. So I really appreciate you kind of highlighting that because we can make an impact on these other things, and it's worth following up with them, as you pointed out, throughout their treatment because of that generalization. So it's a good message to kind of get reinforced.
Absolutely. I think, it's probably a combination of things, if they're building rapport with you, they're coming in and they're building a relationship, they're checking in, they're feeling supported, and then you build self-efficacy when you've treated their opioid use disorder, and, they're seeing they can already make a change in some substances that they're using and they're finding a benefit from that, that can potentially create a snowball effect of like, oh, if I can do this, I can do other things as well. So yeah, thank you. I appreciate
Exactly.
that.
That's exactly it. Yeah. Can we go to the end of the slides here and then we'll wrap up since we're at time. Appreciate everyone who's been able to join us and stick around. Really. All right. So our ongoing ADI trainings, there's the monthly jail MOUD call. On the second Tuesday, there's the monthly care navigator call, the second Wednesday of the month, the monthly adolescent, which is the third Wednesday. And I think that's actually today, later at 12 o'clock. And then the quarterly
Yes.
emergency call. I don't know for there it is, fourth Tuesday of the month. And next one I think will be in January. And to register, you can send an email to ADI and ask about those. Anything else? All right, and there's our resource list. And is that about it?
And that's it. Yeah, we'll have more
Okay.
trainings posted for 2025, but the calendar invites haven't been created yet.
All right. Thanks, Maureen. Well, with that, we'll sign off. Thank you all for joining us. I hope you have a good rest of your day, good holiday season. Bye-bye.